Why don't we need a wellness center? Oh, wellness center is not good enough?
I guess not.
I think they should have built it where they built the parking lot.
What's that?
Because we had our parking lot. Yes.
But they needed more parking space.
Yeah, but they took up half the parking lot.
Okay, good morning.
Morning.
Oh, come on. Good morning.
Good morning.
Thank you. Good. Okay. Gas exchange and transport. Later. We got to finish yesterday. So is Giancarlo here? No. We need this guy's name pronounced with the Italian accent, I think. So maybe he'll be here by the time we get back to him.
Paul's a good actor.
Who's that?
Paul's a good actor.
That's Giancarlo.
Yeah, that's what I meant to say. Thanks for the reminder.
Okay. Maybe Steve could do it. Okay. Okay. What we talked about yesterday, after the kidney, talked about the structure of the upper airways, the nose, the conducting airways, which is considered the dead space because there's no gas exchange. It's just the tubes that get the gas to the alveoli, and then the structure of the alveoli. One of the things you talked about was the important features: cartilage, mucus secretion, smooth muscle in the trachea and bronchi. No cartilage, but lots of smooth muscle, still mucus secretion in the bronchioles. And the bronchioles, because they don't have the cartilage, can collapse. Mentioned that most of the mucus comes from the trachea and bronchi, from the submucosal glands, but that there are epithelial secretory cells in the trachea and bronchi and in the bronchioles. Had a question from Giancarlo about, if you lose your ciliated cells, can they regenerate? And I said, no, but then thought about it, and yeah, of course they can. Because in diseases such as asthma, COPD, at least initially, you get a hyperplasia of the ciliated cells. So you get more ciliated cells initially. In COPD, eventually you lose them. And so you can't move the mucus out with the ciliated cells in COPD, like you can normally. But in asthma, you get a hyperplasia of the ciliated cells. So yes, they can regenerate. The other thing was that the secretory cells in the epithelium of the bronchioles are now called club cells. They used to be called Clara cells, and I was right. The guy Max Clara, who first described them, was found to be associated with the Nazi Party, and some of the tissues that he took, including the ones that he used to identify the Clara cells, were taken from prisoners of war. So worldwide, the respiratory societies, when they discovered this, decided to remove his name from the cell type and call them club cells. They secrete mucus. The other thing that they do secrete that I didn't mention is they do secrete some of the proteins that get involved with the surfactant to, the A, B, and C proteins. Alveoli, close proximity between the inspired air and the pulmonary capillary blood. There's cell layers either side, interstitium, basement membranes and interstitium. The interstitium has elastic fibers, and these are the fibers that help collapse the lungs during expiration. Surfactant is produced here. This helps reduce the surface tension of the alveoli to stabilize them, help them stay open, and it also, since they're lipids, they can dispel the water. They're hydrophobic, dispel the water from the alveolar spaces. Okay. So a question for you. So which is not true about airway mucus? Stop it? Okay. Ready? Okay. Okay. Well, the bottom one is correct. They are all true, but everyone's a winner. So contains immunoglobulin, sure, that's true. And normally cleared by ciliary action, can be cleared by cough. All true. Okay. All true. Any questions? Particle deposition, so you don't need to remember these exact sizes, just that clearly the larger particles get deposited in the larger airways. The smaller particles that can, go with the flow can penetrate deeper into the airways. So the smaller ones get deposited in the bronchioles. The really small ones can, get inspired and get exhaled as well. They don't deposit at all. So it depends upon the size and the shape of the particles, whether they're the airflow can cause them to come in contact with the mucus or not. If they come in contact with the mucus, they're going to get trapped. If not, then they can get expired. Fortunately for cigarette smokers, a lot of the inhaled particles are small enough to get expired. So not everything in the cigarette smoke gets deposited in the airways. Okay. Enough gets deposited to cause them problems, but not everything. So the real small ones, they can get exhaled again. Okay. There's a lot of words on this slide. Okay. How do we breathe? Okay. Well, there's two forces opposing each other. The lung elastic fibers want to collapse the lungs, but the anatomy of the rib cage wants to expand. And so at the end of normal expiration, these two forces are balanced out. To inspire, and there's a pleural cavity around the lung tissue, and there is some fluid in here, but not much. And there's a negative pressure in the pleural cavity. It's a pretty small negative pressure. It's about -3 millimeters of mercury, -5 centimeters of water, but it is enough to hold the lungs, the airways open. When we breathe in, it is an active process. The main inspiratory muscle is the diaphragm. So under normal conditions, all you use is the diaphragm for inspiration. And that sort of pulls down on the rib cage, and it increases this negative pressure in the pleural cavity. So it becomes more negative. And so that helps to pull the airways open even more, and it draws in air through, the nose, the mouth, whatever we're doing. So this is inspiration. It's an active process, muscle contraction, mainly by the diaphragm. Increasing this negative pressure, expand the lungs, and create airflow. Normal expiration is passive. You don't use muscles to do it. It's the elastic fibers now in the alveolar interstitium that help collapse the lungs until you come back to where the forces are balanced. The anatomy trying to expand it and the elastic forces trying to collapse it. And so that would be end expiration. So inspiration, this is normal conditions. Inspiration, active with the diaphragm. Expiration, passive just because of the elastic fibers. There are other muscles that can be involved in respiration. And these accessory muscles come more into play in airway diseases such as COPD. Right, the next few slides are going to be a review for you. This is what we did in 371 under lung function testing. As I said yesterday, before this semester, this year, this is where we covered this material. 371 was a completely different class last year. So measuring lung volumes, lung flows, helps in diagnosis of respiratory diseases. If someone is being treated, then it helps to assess whether the treatment is being effective or not. This is the way it's normally done these days with a, this is the modern type of spirometer. You can see these, and you probably see this in the skills lab, peak flow meters. These are often used by asthmatics. It doesn't give the same measures as you can do with a spirometer, but it gives a peak expired flow, which is a good indicator of the functioning of the larger airways. Helps assess whether an asthmatic is, disease is stable or not, or whether they go into an exacerbation or something like that. Not all of the lung volumes and flows can be measured by a spirometer. And two important ones that cannot are total lung capacity, the total amount of air that is in the airways, and something called residual volume. And residual volume is the amount of air that you cannot expire from your airways, no matter how hard you try. And the reason for that is because the airways collapse. When you get to a low lung volumes, these bronchioles collapse, trap air behind them. That is residual volume. These two volumes cannot be measured by spirometry. They need some other method to do it. There's a dilution method that used to be used. The normal method now is this whole body plethysmography that we described, in the other class. So how's it done? How's normal spirometry done? Deep breath in, maximum inspiration to total lung capacity, and then a rapid expiration, and you expire as far and as fast as you can. And the amount that you can expire from that total lung capacity until you get down to you can't expire anymore, you got to your residual volume, that is your vital capacity. Okay. So lung volumes, capacities, your resting breathing is about 0.5 liter per breath, about 15 breaths per minute. So your total ventilation is about 7.5 liters per minute. So you can't inspire beyond total lung capacity. You can't expire below or beyond residual volume. And so normally you're breathing along here, 500 mils, 15 breaths per minute. Maximum inspiration to total lung capacity. And if you expire as far as you can, then you get to residual volume. Okay, so this is your total lung capacity here, from here down to here. This, from the maximum that you can breathe in to here, is your vital capacity. And there are some others, functional residual capacity. You don't need to remember these. I mean, the important ones are your vital capacity, your residual volume, total lung capacity, and the other one is forced expired volume in 1 second. So if you have a full inspiration to maximum lung volume, breathe out as far and as fast as you can. The important measurements are forced vital capacity, which is the whole amount you can breathe out, and the amount that you can breathe out in the first 1 second. And this is really a measure of the state of the larger conducting airways. So the trachea, the bronchi, the major bronchioles. Under normal conditions, healthy subjects like you guys, forced vital capacity, now it depends upon gender, it depends upon size, it depends upon age. But as I say, in general, in you guys, forced vital capacity is around 5 liters. And the FEV1 in a healthy lung is about 80% of the forced vital capacity. So it would be about 4 liters for you people. We will come back to this for when we talk about the diseases, because the forced vital capacity and the FEV1 change in obstructive diseases, asthma, COPD, cystic fibrosis. They change differently in restrictive diseases like pulmonary fibrosis. And it's a way of diagnosing helping diagnose these different conditions. And the other way you will see this lung function testing displayed is by flow volume loops. And this is done slightly differently, because this is a forced inspiration and a forced expiration. And so the forced expiration is exactly the same as we've just described, from maximum lung capacity here, forced expiration to residual volume, and then a forced inspiration. And it just sort of mirrors what you see with the expiration. And so this is what you would see in a normal type of lung, healthy lung. Again, there are changes in airway diseases in these flow volume loops that are helpful in diagnosing the condition and seeing if treatment is being effective. In the conditions we will talk about, one thing that we will see is that residual volume certainly is increased in obstructive diseases as well. And often it's increased in restrictive diseases. This means that the airways are collapsing at a higher lung volume. So the people cannot breathe out as much gas, so they have a higher residual volume because of the obstruction and changes in some of the peripheral airways. Okay. Sometimes when you breathe out really fast, especially in people who have airway obstruction, you can't get to your, the airways will close sooner because of the forced way that you're expiring. So one thing that you may see, instead of doing a forced vital capacity, you may see something called a slow vital capacity. And so the FEV1 would be gotten the same way, with a forced expiration, but then the full vital capacity would be done differently. And it would be from total lung capacity, maximum inspiration, and then just a slow exhalation all the way down to residual volume. This tends not to collapse the airways as much. And so you might get, be able to breathe out more air with a slow expiration than you can with a fast expiration. You may get to a lower residual volume. You may see that described in the literature. Typically, though, it's always done just from a forced expiration. One thing this is the way I like to look at this, because it sort of gets some important points across. One is that every time you breathe in, you breathe out, you don't exchange all of the air in the alveoli. You exchange just a little bit of it. And so the alveoli are typically expanded all the time with air, which is good because it means that all the time you have gas exchange going on. So it's not as though you empty it all out and the alveoli are completely empty and then you breathe in again. The alveoli are expanded all of the time. And the amount that is breathed in and out each time is only about 15% of the alveolar volume. So it's a small amount that is exchanged every time you breathe in and you breathe out. So if you look at, it could be an alveolus, but it's one of these terminal structures, the bunch of grapes, the collection of alveoli. They can collapse when you breathe out far enough, so they have a residual volume. And so they always have this amount of gas inside them. Normally, you're breathing in this region here, the white region. So your tidal volume is only exchanging a small amount of air in the alveoli anytime that you breathe in and you breathe out. The other thing to think about dead space. The dead space, the conducting airways, is about 150 mLs. Now, if your tidal volume, what you breathe in, is 500, then 150 of that is not getting to the alveoli. So your alveolar ventilation is only 350 mLs of this half liter that you breathe in. So there's always air in the alveoli, about 2 liters at the end of normal expiration. So you've got continuous gas exchange, and I say there's just this small amount exchange, about 15% every time you breathe in and out. But it's enough. This 15% is enough to maintain steady states of oxygen and CO2 in the alveoli and in the arterial and venous blood. The diagnostic tests, and I forgot a couple that we covered in 371, so I put them in here in red. So we'll talk about this on the next slide. Stethoscope on the chest is called lung auscultation, and this is where they listen for breath sounds. Chest X-rays and CTs are typically used to look for changes in the alveoli. We'll talk more about blood gases and oxygen saturation. Lung diffusing capacity we have talked about. We'll come back to that. There's allergen testing in asthma to see if people are allergic to specific things to try and help diagnose the condition. There's other tests that are used in asthma as well. Bronchial provocation to see whether the airways are hyperresponsive. So you give someone histamine or methacholine, bronchoconstrictor to inhale and see how they respond. Exercise, some people have exercise-induced bronchospasm, so they can be challenged with exercise to see if they really have it or not. One of the more recent tests is measuring the exhaled fractional amount of nitric oxide. Nitric oxide is produced by eosinophils and in large amounts. And so it's a test for someone who has allergic, i.e. eosinophilic driven asthma. Genetic testing for emphysema and COPD, and again, we'll come back to that. And then certainly in COPD, but in pulmonary fibrosis as well, and in asthma, there are, in severe disease, cardiovascular complications. So cardiovascular exams are common. Lung sounds. The ones that you will come across and probably should remember, at least recognize the names of, are the ones in red. Sounds are described as musical or non-musical. And until you've heard them, it's really difficult to sort of know what this means, but musical means that it's, that the sound goes up and down in a sort of a musical fashion, whereas non-musical, it's just a sound, it's just there. Now, could it still be musical? Sure, it depends on what type of music you like, but so you'll see this described as musical, non-musical. Common ones, wheezing, and this is often heard in asthma because it's a sign of blockage and narrowing of the airways. Rhonchi, which is similar to a wheeze, but it is a lower pitch, and this is more indicative of secretions in the airways and air sort of going through and over secretion, so more in bronchitis and COPD. The others that you will see are crackles, and they are called fine or coarse crackles. These are non-musical. The first two are considered musical. These two are non-musical, and they're seen in inspiration, in pneumonia, fibrosis. So these are sounds probably coming from more peripheral airways. And then coarse crackles, you see these called this as well, R-A-L-E-S. This is pronounced rawls, not rails. Okay. These are, again, non-musical, seen on inspiration, expiration. Again, it could be secretions in COPD. So These are the ones that you'll see most commonly described in you know, case studies and things like that. Strider, pleural rubs, squawks, you know, less common, at least in the literature. Okay, I think we don't need to do this. Residual volume, gas you can't breathe out, no matter how hard you try. What's the real cause of this? How many for A? B? C? Okay, and not D. Okay. Any questions? Boy, half a class behind already. Okay. We were supposed to be starting this one at 8 o'clock. Giancarlo's still not here, so I'll have a go. Evangelista Torricelli. Okay, where do you think he's from? Dallas? Yeah, sure. Okay. He's from Italy. He was an Italian physicist. Anybody look him up?
No.
Okay. So he invented the barometer. Okay. He did other stuff as well, but this is the most famous thing that he's remembered for. It's also used to be called the Torricelli tube. And what he did was he took mercury in glass tube, long glass tube. It was sealed at one end, and he put the other end, he filled it with mercury, and he put the other end in a dish of mercury. And the level came down in this tube. You remember how high the column is? Never did this in physics. 76 centimeters, 760 millimeters. 760 millimeters of mercury is 1 atmosphere. So the atmosphere can support a column of mercury 76 centimeters high. Do you ever play with mercury in chemistry? No, see, I guess you can't do that these days. It is fascinating to start putting your fingers in mercury. It's really weird stuff. Okay. What's that? In chemistry? Oh, sure. Yeah, we used mercury and things like that. You put your finger in it. Yeah. We had asbestos in houses and, lead in paint, and we still all lived okay. So, okay. Okay. We're going to come back to him in a little bit because there's something named after him other than the barometer, the Torricelli tube. Some other things that we're going to talk about which sort of relate to physics. We're going to talk about partial pressures of gases because these are real important for determining the carriage, the transport, and the exchange of gases, the oxygen, the CO2. And we'll also talk about how the gases are transported, hemoglobin, CO2, hemoglobin, plus changes to other compounds, and factors that influence the binding release of the oxygen and of the CO2. Okay. Hypoxia. What's hypoxia? Lack of oxygen where? In the body, yeah. Anything other than the blood?
Tissue.
In the tissues. How about the air? Okay, so here we go. Low oxygen in the alveolar air or in the tissues. Hypoxemia. Hypoxemia.
Oh.
The blood, okay. Low O2 in the blood. So hypoxia is in the air or the tissues. Hypoxemia is specifically in the blood. Hypercapnia. Hyper. High. What are we going to be talking about? Oxygen and CO2. High CO2 air, blood, and tissues. There is not a hypercapnemia for the blood. It's just hypercapnia. And hypocapnia, low CO2, air, blood, and tissues. Okay. Any idea what capnia means? Comes from the Greek word meaning smoke. Because if you burn something, you give off CO2. Well, most things, not all things. You burn potassium nitrate, you give off oxygen, but okay. Okay.
Which is always exciting.
What's that?
Which is always exciting.
Sure. Partial pressure of gas is proportional to the relative amounts. So at sea level, 1 atmosphere, the total pressure is 760 millimeters of mercury. It's also called 1 torr, after Evangelista. Okay, Torricelli. Okay, you get it. Okay. So partial pressure of oxygen, 21% oxygen in the atmosphere. Partial pressure of oxygen, 760 times 0.21, 158 millimeters of mercury is the partial pressure of oxygen in the atmospheric air. Partial pressure of CO2 at 0.04% is 0.3 millimeters of mercury. So once gases meet solution, then they have partial pressures in the solution as well. You know, and that is partially determined by solubility as well as the total amount that is there. So there are different partial pressures of oxygen and CO2 in the atmosphere, the alveolar air, arterial blood, and venous blood. And the important ones to remember are the ones in the red and the blue. Okay, so the arterial and venous blood partial pressures of oxygen and CO2. So the inspired air, oxygen, so it's 158 millimeters of mercury. In alveolar air, it's about 100. Why is it not 158? Well, because you don't exchange all of the alveolar air each time you breathe in and out. So the alveolar air is about 100 millimeters of mercury. Arterial, partial pressure of oxygen, about 95 millimeters of mercury. Why isn't it the same as alveolar? Because there is some shunting, small amount of shunting of blood. Some blood bypasses the pulmonary capillaries. So it doesn't go from, you know, the pulmonary vein, pulmonary capillaries, pulmonary artery. It goes from the pulmonary vein to the pulmonary artery without going through the capillaries. So the arterial blood, a little bit of it does not get exchanged in the alveoli. So slightly less partial pressure of oxygen in the arterial blood. And then in the veins, so when the arterial blood gets to the tissues, gives up the oxygen. After that, coming back in the venous blood, the partial pressure of oxygen is about 40 millimeters of mercury. So lost the oxygen and lower partial pressure. And obviously the CO2 goes the other way. The arterial PO2, or the venous PO2, so from the tissues it's 46. In the arteries coming in, it's 40. So when the blood gets to the tissues, it takes up this CO2 here. Small amounts in the inspired air, and the alveolar air is the same as the arterial. So the pulmonary venous blood comes in and loses CO2 to the alveolar air and then to the atmosphere. So if you plot it, it looks like this for oxygen and like this for CO2. Okay. So the ones to remember, the 95 and the 40, the 40, the 46. Oxygen and CO2 dissolve in solution. And so some dissolves in the blood. Not enough dissolves in the blood to carry enough oxygen for the demands of the body, and does not carry enough CO2 to get rid of enough from what's produced by the body. So there are other mechanisms for carrying to increase the carrying capacity for oxygen and CO2. For oxygen, it is hemoglobin. And this increases the amount the blood can carry by 70 times. So huge increase in carrying capacity because of the hemoglobin. And the CO2 capacity is increased because it gets converted to other compounds. And because it also, some of it binds to hemoglobin as well. So the carrying capacity for the CO2 is increased as well, but not as much as the oxygen carrying capacity. So most of the oxygen and CO2 in the blood is carried by hemoglobin or in other forms for the CO2. However, the PO2 and PCO2, the partial pressures, i.e. the amount that is dissolved in solution, is still real important for some important reasons. They drive the binding of the PO2, the partial pressure of oxygen, drives or determines the amount of oxygen saturation of the hemoglobin. It also, the differences in partial pressures between the blood and the tissues drives the oxygen from the blood into the tissues and drives the CO2 from the tissues into the blood. So the partial pressures are important for determining the amount of binding, but also driving the gases between the tissues and the blood. Obviously, think about it just for the oxygen. So the partial pressure of the oxygen in solution is what goes into the tissues. What happens then is that means that oxygen comes off the hemoglobin into the blood, into the tissues. So the amount dissolves in the blood is what goes into the tissues initially, but it helps drive the rest of the oxygen from the hemoglobin. Okay. So started the alveoli. Gas diffusion between the alveoli and the blood. It's thinking a bit like thinking about the glomerulus. What determines the rate of transfer of plasma across the glomerulus? Well, what determines the rate of transfer of gases across the alveolar membrane? Surface area, and the alveolar surface area is huge. Membrane thickness, it's thin. The thinner the better, because the thicker it is, as in fibrosis, this slows down the diffusing capacity. So large surface area, thin membrane. The differences in the gas partial pressures drive the gas flows from the alveoli into the blood or the blood into the alveoli. Gas solubilities. CO2 is much more soluble than oxygen. So that leads to some differences in how they're, what changes you see in certain diseases. We'll talk about that. And there is rapid equilibrium between the blood, between the alveolar air and the blood. And this picture here just shows, this is the blood coming into the pulmonary capillary. So it's venous blood. And this is the time that it spends in the capillary. And this is the saturation of oxygen. And you can see that it comes in at 40% saturation. This is the PO2, so 40 PO2, and it gets up to the alveolar PO2 of 100 millimeters of mercury, and it's been in the capillary less than half a second. So it is really rapid equilibration. The exchange is decreased or slowed in lung diseases, and I put decreased in just to try and clarify this first bullet here. In emphysema, in COPD, there is alveolar destruction. So the surface area of the alveolar membrane, the area for diffusing, is decreased because the tissue is lost. So there is less gas exchange because of a smaller surface area in emphysema. The membrane itself is not thickened, so the rate of transfer across it may be the same in any alveolar unit, but there's few alveolar units, and so the total amount of diffusing capacity is decreased. So there's decreased oxygen delivery and decreased CO2 removal in COPD because this is the loss of surface area. In lung fibrosis, and this line here shows what happens in lung fibrosis, is that there's fibrosis of the alveolar interstitial tissue. And we'll talk about the mechanisms later, but it creates a thickening of the tissue. So it's more difficult for the gases to diffuse across this thickened membrane, and so it takes much longer for the blood to equilibrate with the alveolar air in lung fibrosis. And it may be that the equilibration is not complete by the time the blood leaves the pulmonary capillary, which is going to lead to a decrease in the oxygen in the arterial blood. So decreased exchange in emphysema because of loss of surface area, decreased rate of exchange in lung fibrosis because of the thickening of the alveolar membrane. Used to cover this in biochemistry with Dr. Domina. Now that Dr. Cato teaches most of this, I don't know whether you still do this. You talk about hemoglobin?
Yep.
In bio, okay. Because I used some of the slides that Dr. Domina used to use, but now did Dr. Domina or Dr. Cato teach this? Okay. Did Dr. Domina teach anything? Okay. Okay. So hemoglobin, there's 4 subunits. Usually, most normal hemoglobin, 2 alpha subunits, 2 beta subunits. You do have some other subunits, and in fetal hemoglobin, you get the gamma. Sickle cell hemoglobin, you've got an S type, and then there's a minor type of adult hemoglobin where it's an alpha 2, delta 2, but mainly it is alpha 2, beta 2. 4 subunits of together. These are the changes over time, developmental changes over time. So this is in the fetus. So the alpha chain is there all the time. In the fetus, you've got the gamma, which disappears at birth, and the beta one takes over. And then in adults, there's this small amount of a delta chain as well. So a minor one in adults, major one is the alpha 2, beta 2, and the alpha 2, gamma 2 is fetal. When oxygen binds to the iron porphyrin ring, it produces conformational changes. First of all, it needs the iron, the ferrous, in the ferrous state, not in the ferric state. If it's in the ferric state, it decreases binding. This is called methemoglobin. It needs to be it should be in the ferrous state. The binding of each of the four subunits binds an oxygen molecule. The first one that binds causes a conformational shift in the rest of the hemoglobin structure. And this conformational shift facilitates the binding of the other 3 oxygen molecules. And this is called cooperative binding. So the first one binds, conformational shift, and it allows the other 3 to bind more easily. There's also other conditions that can cause conformational changes that help the binding of oxygen. And pH, low pH, i.e. hydrogen ions, CO2, high CO2, increased temperature. What are these all indicative of? Hydrogen ions, CO2, temperature in the tissues. Metabolism, right? So you've got metabolic activity. And so when the blood gets to the tissues, out of the blood, then you have all of these factors. You've got hydrogen production, you've got CO2 production, you've got increased temperature. And so these facilitate the release of oxygen from the hemoglobin. And also 2,3-diphosphoglycerate, which is produced during exercise. We'll talk about that in a little while. So these allosteric changes, by these factors, when the blood gets to the tissues, helps the hemoglobin release the oxygen into the tissues.
I have another semantic comment if you want to hear it. So the 2,3-DPG is also 2,3-BPG.
Correct.
Diphosphate
Yeah.
versus
Yeah.
bisphospho. So biochemically, diphosphate would be two phosphates that are linked to each other. But in this molecule, they're on different carbons. The proper name is bisphosphate.
Okay. Thank you. Did you get that? So
ADP, the two phosphates are linked to each other. Adenosine diphosphate. In this case, they're not linked to the same carbon.
So this is BPG. So this is bis.
Yes.
Okay. So it's bis and not di. Okay. I do have bis on another slide.
Okay.
So it's my mistake. Okay. Okay. So this is, you'll see taut and relaxed states for hemoglobin. And the taut is when, there's no binding. And the high affinity is the relaxed state. So after you've got the first binding, you get the high affinity state. Okay. You see this in biochem? Okay. Okay. So this leads into the oxygen hemoglobin dissociation curve. And you've seen this before? Okay. If you plot the partial pressure of oxygen, so this is in the blood, against the percent oxygen saturation of the hemoglobin, then you get this sigmoid-shaped curve. And alveolar blood, we've said the PO2 of alveolar air is about 100 millimeters of mercury. PO2, about 100 millimeters of mercury. So alveolar air. And this gives close to 100% saturation of the hemoglobin. So you can maybe bind a little bit more, but not much. It's 98% plus saturated with oxygen at 100 millimeters of mercury that you get in the alveoli. The venous side here, 40 millimeters of mercury for the PO2, and this represents about 75% saturation of the hemoglobin with oxygen. So when the blood goes from the alveoli to the tissues, this is the amount of oxygen that it gives up from the blood to the tissues. Okay. So this small dotted line here is the amount of oxygen that is dissolved in the blood at these different partial pressures. So you can see that there is a small amount dissolved, but clearly, most of the oxygen is carried in the hemoglobin. Okay. So the oxygen saturation of the hemoglobin depends upon the partial pressure of the oxygen in the blood. Let's come back to that tomorrow. Okay. Any questions? Okay. So we'll carry on from here tomorrow, talk about why it's sigmoid. And when we look at the CO2 dissociation curve, it is not sigmoid, it's more of a straight line. So there are reasons for both of these factors.